make it practical yet evidence-based. So we're going to try and cover classification, investigation, management, and finish off with some cases. So in terms of classification, as you know, the hemodynamic classification for pulmonary hypertension has changed over the last couple of years. We used to use a threshold of 25 millimetres of mercury, but it was well appreciated that a pressure of over 20 millimetres of mercury was not normal. And so the most recent hemodynamic definitions use a threshold of 20 millimetres of mercury and right heart catheterization to define pulmonary hypertension. It's a wedge pressure with PAWP, which is a marker of left atrial pressure. If that's less than or equal to 15, that suggests that the pulmonary hypertension is pre-capillary, i.e. the problem is before the pulmonary arteries, assuming that your resistance is elevated over 2 units. And then patients with high wedge pressures have post-capillary pulmonary hypertension. So all or some of the pulmonary hypertension results in back pressure from the left side of the heart. And that can be isolated if the PVR is low, or maybe a combination of the two processes if the PVR is high. In terms of clinical classification, as you know, there are 5 groups based on shared pathophysiological features. So group 1 is pulmonary arterial hypertension, group 3 is pH related to lung disease, and group 4 is pulmonary hypertension due to chronic thromboembolic disease. These are all pre-capillary pulmonary hypertension. Group 5 is a mixed bag, including things relevant to respiratory conditions such as sarcoidosis or Langerhans cell pseudocytosis. Some of the group 5 can be pre or post-capillary. And then group 2 is the pulmonary hypertension related to left heart disease. That can be systolic dysfunction, but very commonly diastolic dysfunction, and also can be valvular disease in nature. And the form of pulmonary hypertension impacts not only on your treatment, but also on your survival. You can see here data from our centre showing that, for example, if you've got PAH related to congenital heart disease, you have a much better survival than pulmonary hypertension related to systemic sclerosis. Now, if we look at pulmonary arterial hypertension just for a moment, it's a quasi-malignant process with proliferation of the intima and media. So this is a nice thin-walled pulmonary artery on the left, and as the disease progresses, the intima and the media are becoming thicker and the lumen is becoming narrower. So at the bottom you'll see a normal atrial four chamber view with a small right ventricle on the left, and as the disease progresses, the afterload increases, the RV dilates. It's not hard to see that by the time you get to the right, this is a severely life-shortening condition. And in terms of pH, there are various forms of it. It can occur out of malignant idiopathic disease. It can occur in families, and there are various genetic abnormalities associated with the development of pH, VMPR2 being the most common, but quite a number of genetic mutations being observed and demonstrated over recent years. Various illicit or licit toxins, including amphetamine or methamphetamines, and including things such as tyrosine kinase. Connective tissue disease is an important cause of PAH, with systemic sclerosis being associated with PAH in around 5 to 7% of people. Liver disease, patients with significant portal hypertension, around 5% of people will develop PAH, we call that portopulmonary hypertension, and congenital heart disease is clearly an important cause of pulmonary hypertension. So how do we investigate for pulmonary hypertension? Well, this is the diagnostic algorithm from the ESC guidelines, which is fairly busy and quite slightly confusing. So we can simplify it. You've got to suspect pulmonary hypertension, then you've got to detect it, and then you've got to confirm it. So to suspect pulmonary hypertension, the first thing is always history, and the history clearly is a progressive exertional breathlessness, not with wheeze, not like asthma, but exertional progressive breathlessness. As the right ventricle starts to fail, then the patient develops increased right atrial pressure, starts to develop peripheral edema. If the RV is very dilated, or there is compression of coronary artery by a very dilated PH, they will get chest pain, but that's not common. Syncope is always a worrying concern because it means the cardiac output is very tenuous and can't increase on exercise. Risk factors are important to increase our pre-test probability. We talked about those conditions associated with an increased risk of pulmonary arterial hypertension, but there are also things associated with increased risk of chronic thromboembolic pulmonary hypertension. That can include previous DVT or clot, or PE, but also can include other things such as chronic inflammatory conditions, especially inflammatory bowel disease, splenectomy, myeloproliferative disease, so polycythemia vera, or essential thrombocytosis, previous infected pacemaker leads, which are infected clots, which are very thrombogenic, and patients who might have had a VA shunt for hypertension. So just put those in your mind, that if you see patients with those conditions, think about could it be chronic thromboembolic disease with pulmonary hypertension. To detect it, if you have an ECG like this, it's very clear that this is abnormal with right heart strain, right axis deviation, right ventricular hypertrophy. Very suspicious of pulmonary hypertension, precapillary pulmonary hypertension. But if you're looking for mild disease, the ECG might be normal. Chest X-ray shows cardiomegaly with large pulmonary arteries. Again, that's very suspicious, but patients with mild disease might have a normal chest X-ray. Echocardiography is the main tool of use. It's always useful to know what you are, what you're getting back on your echo report. So to estimate the pressure, this is based most commonly on the TR velocity. So this is severe TR from the right ventricle to the right atrium. You put your continuous wave Doppler, which gives you your velocity here. You square this, square that times by 4, that gives you a pressure gradient across the tricuspid valve. And if you add an estimate of right atrial pressure, that will give you an estimate of the systolic, not the mean PA pressure. So in terms of probabilities of pulmonary hypertension, if the TR velocity is over 3.4, that's highly suggestive of pulmonary hypertension. If the TR velocity is less than 2.8, pulmonary hypertension is unlikely, assuming the rest of the heart looks okay, and if it's in the middle, it's in the middle. But there are other features which refine that probability. So, for example, if you've got a 4 TR envelope, you can underestimate TR velocity, but if the RV is dilated, that might suggest pulmonary hypertension, or if the acceleration time is reduced or the IVC is dilated. So these other features we put together with the TR velocity to estimate the likelihood of pulmonary hypertension. Other simple tests, so your spirometry in PAH can often be slightly impaired, but not dramatically. Your gas transfer in idiopathic PAH is normally around 60 to 70%. It's normally low in scleroderma-related PAH. But if it's very low, less than 45%, it suggests there's something else going on, such as lung disease or a rare condition called pulmonary veno-occlusive disease. And then to confirm the diagnosis of pulmonary hypertension, we move to imaging. So a VQ scan or a Q scan is the most sensitive way of demonstrating or excluding chronic thromboembolic disease. You see on the left a very normal VQ scan, on the right very abnormal wedge-shaped defects throughout, keeping with chronic thromboembolic disease. But the CTPA, which many patients will get, can tell us a lot of information. You can often diagnose what form of pulmonary hypertension patients likely to have before you even need to do right heart catheterization. So a systematic approach to CTPA interpretation is very important. So first I look at the main pulmonary artery in red, here at the bottom left. Is that dilated? Bigger than 3 centimeters is bigger than this main also. Then I move up a little bit down to the right ventricular outflow tract to see is there hypertrophy. That suggests there is chronic increased afterload on the right ventricle. So it's greater than 6 millimeters. Then I look at the cardiac changes. On the right side of change is enlarged anteriorly. Is there abnormal pulmonary venous draining into the left atrium? Is there an obvious atrial septal defect? This atrial septal defect is quite easy. Then I look at the mediastinum. Are there signs of chronic pulmonary arterial hypoxemia, such as bronchial artery hypertrophy, which you get in chronic thromboembolic disease and also in isomegas? Is there a large esophagus, for example, in patients with systemic sclerosis? Then I follow the pulmonary arterial tree out. Is there evidence of filling defects? Here there's clear evidence of mural calcified proximal thrombus, but sometimes it's more distal, you have to follow the pulmonary arterial tree, whose anatomy follows the bronchial tree, which everyone will know from bronchoscopy. Then I flip to look with those, is there parenchymal lung disease? In this case, you'll be able to see mosaicism with high areas of high attenuation in keeping with high perfusion, and areas of low attenuation in keeping with poor perfusion, in keeping with chronic thromboembolic disease. And then I look outside of the lungs, especially the liver. Is there evidence of TR with significant hepatic reflux? And is there evidence of cirrhosis or splenomegaly suggested of pulmonary hypertension? So most patients you will have a very good idea of the likely diagnosis if you go through the CT in a systematic method. Right heart catheterization, I appreciate this can be difficult depending on your healthcare system. We measure pressure, we measure cardiac output, flow, we measure saturation, and sometimes we do other things such as give nitric oxide, fluid, or exercise. It's clearly important for all patients to have a right heart catheterization to fully phenotype this patient. However, as I've said before, as I've said, you can often come up with a diagnosis based on the injury. This is a small gas catheter which is floated through the right heart. This is a balloon at the tip which flows through and wedges here and gives you the estimate of the left atrial pressure. So what about management of pulmonary hypertension? Well, as you know, in terms of medical therapy for pulmonary arterial hypertension, there are three main groups of treatments. Endothelium, one is producing the endothelial cells as opposed to vasoconstrictor. So you can block endothelium with an endothelial receptor antagonist, that could be both sentinel and macicenter or ambricenter. Nitric oxide is a vasorelaxant produced from L-arginine. It's a very potent vasorelaxant agent. And so nitric oxide works via cyclic GMP, so you can prolong the action of cyclic GMP by inhibiting PD5 upstream down. So PD5 inhibitors sildenafil and tadalafil. Riociguat is a soluble one-like cyclase stimulator which works slightly dependent on nitric oxide. That's an NO pathway, and the third pathway is prostacyclin pathway, which again is produced endogenously and is a very potent vasorelaxant. And so you can augment that with prostacyclin analogs, prostanoid alloprost, or you can do selective package which works with an IV receptor. And if you look at approved therapies over the last 30 years, you'll see a number of these treatments that have been approved based on large randomized trials over these last 2.5 decades. In terms of the future of new drugs, sotatercept acts by a different pathway. It works on the TGF-beta superfamily and essentially tries to move from a pro-proliferative balance to an anti-proliferative balance by acting the ligand trap or activin and GDF to prevent activation of the pathway on the right, which aims to then stimulate activation of the anti-proliferative pathway. And sotatercept has recently been shown to be a very beneficial drug from the STELLAR study, which enrolled patients who were on background therapy and had a diagnosis quite a number of years ago. Despite that, there was a significant improvement in exercise capacity in patients receiving sotatercept, and also, importantly, a large number of secondary endpoints, NT-proBNP, resistance, functional class, all improved in patients receiving sotatercept. Importantly, around 10% of people with idiopathic PH will exhibit acute vasoreactivity to inhaled nitric oxide. 50% of those will have a really great prognosis with high-dose calcium channel blockers. That's one of the reasons why right heart catheterization is really important, especially considering idiopathic PH. We give them inhaled nitric oxide and we identify these patients at the top who will have a very good outcome if you treat the correct drug. So how do we put these drugs together? Well, this is the ESC treatment algorithm, and it acknowledges that increasingly we see patients with cardiopulmonary comorbidities, so more elderly patients who have either cardiovascular risk factors, ischemic heart disease, atrial fibrillation, systemic hypertension, or a significant smoking history, and maybe a tiny bit of lung disease. For those patients, it's suggested that they receive initial oral monotherapy, generally with PD5, and then assess whether those patients improve. For those patients without cardiopulmonary comorbidities, then we base our treatment on risk stratification. Basically, those patients at increased risk, at high risk of poor survival in the first year, should be offered, if appropriate, intravenous prostanoid therapy in conjunction with combination with oral therapy. For patients at lower or intermediate risk, then these patients, on the basis of studies such as the ambition study, which showed that receiving tadalafil and ambrisentan was superior to receiving one of those drugs, or combination therapy is given. And risk stratification is based at baseline on this three strata: low, intermediate, high risk, and it involves various parameters you can see there, including rapidity deterioration, heart failure, exercise capacity, hemodynamics, NT-proBNP. There's quite a lot of those parameters you can choose. So that's the baseline risk stratification. The next approach is at 3 or 4 months to reassess this patient and assess what's happened after that initial treatment. If the patient improves significantly down to low risk, they can continue with their initial therapy. If they worsen to high or intermediate high risk, then we should again be considering intravenous therapy. And if they remain in intermediate low risk, then we have the option of adding in, for example, selexipag or possibly switching to riociguat. And that's based on a 4-strata risk assessment, sort of based on the Pulmonary study. Basically, you check the functional capacity, exercise capacity, NT-proBNP, and you give a point, 1, 2, 3 or 4 points, depending on which colour they're for each of those parameters, and then you add those together and average it to divide by 3, and that gives you the nearest integer will give you your risk. So that's risk stratification. For PAH, what about therapies outside of PAH? Well, there's a lot of pulmonary hypertension related to lung disease, and unfortunately, there's not a lot of evidence supporting our treatment approach. Quite often, we might give patients trials of medical, for example, but there's no randomized data to support that. The increase study was a very well randomized trial of inhaled treprostinil in patients with various forms of pulmonary fibrosis and pulmonary hypertension. You can see that it improves 6-minute walk distance, and very interestingly, it also improves functional vital capacity in several subgroups. So if it's available inhaled treprostinil for patients with significant pulmonary fibrosis and pulmonary hypertension, is a very appealing treatment modality. You'll see that if you look at the post-hoc analysis, patients with a PVR less than 4 blood units didn't benefit, so patients with slightly more severe disease seem to benefit more, and patients with connective tissue disease related PAH and idiopathic interstitial pneumonia benefited, compared with, for example, patients with combined fibrosis and emphysema. We also see patients, we touched on this earlier, patients with a low gas transfer. It was well recognised by the Dutch group that if you look at patients with a diagnosis of idiopathic PAH with a bimodal distribution of DLCO, so patients with a low DLCO appear to be different. So if we look at survival, those patients do very poorly, and they also respond less well to standard pulmonary hypertension therapy. So this is a recent paper in Chest looking at how we put all this together in terms of treating patients. And essentially, patients with clean or classic PAH to go down the standard treatment algorithm. Patients with significant left heart disease-related PAH or definite severe lung disease-related PAH should generally have treatment there for lung disease, although occasionally we might try a trial of PD5 inhibitor. And those patients who tend to be older with comorbidities or maybe a gas transfer might get monotherapy with PD5, and then depending on how they respond, you might increase therapy or you might stop therapy. In terms of chronic thrombotic disease and pulmonary hypertension, this is a different treatment approach. You'll see here this patient with chronic thrombotic hypertension has undergone endarterectomy. So this is the intima sort of media. This is the right upper lobe, right middle, right lower lobe, left upper lobe, left lower lobe in that endarterectomy sample. So if you can remove the lining of the pulmonary arterial treatment, you can make a massive impact on the right ventricular afterload. You'll see this data quite a while ago from the UK registry showing that at baseline 90% of people will be in functional class 3 or 4, and at 1 year, 90% of patients are in functional class 1 or 2. So if you have access to chronic pulmonary endarterectomy, that is the gold standard treatment for this group of patients. However, for example, in Japan, endarterectomy surgery is rarely done. Most patients have to go through angioplasty. And there is increasing evidence that pulmonary angioplasty can be a very safe and effective therapy. And how do we put this together? Well, this is what the ESC guidelines suggest. There is a randomized trial comparing endarterectomy versus angioplasty, which is a very helpful study. But if you've got proximal disease, that is the realm of endarterectomy surgery. If you've got very distal microvascular disease, then those patients should be treated with medical pulmonary vasodilators, especially riociguat, but often things like sildenafil as well can be effective. And if you're in the middle, so it's just sort of subsegmental disease, then the angioplasty. But again, it depends on what access you have in your local setting. And so just to finish off with some cases to try and put this together, so this is a 90-year-old that did many years ago now, well as a child, several years history of breathlessness. Most patients have a senior history of breathlessness when they present. And no obvious risk factors have been presented acutely and well. ECG, again, very abnormal, so this patient's clearly got something abnormal in terms of their pulmonary vasculature. Cardiomegaly, quite globular, probably related to our diagram. We go on to the echoes, the play. This is the parasternal short axis view here, so this is the right ventricle anteriorly, and this is the left ventricle. You can see flattening of the interventricular septum and systole and diastole. This D-shaped left ventricle. It's consistent with pressure and volume overload of the right ventricle. And when we go on to the atrial chamber view, again we see a very dilated right ventricle, dilated right atrium, and underfilled left heart. Very much in keeping with significant pre-pulmonary pulmonary hypertension. The TR velocity in this case is over 4 meters per second. Square that, it gives you 16 times divided by 4. That gives you 64 millimeters of mercury plus violated pressure. So your systolic pressure is going to be 70, 80 millimeters of mercury. So clearly not severe pre-pulmonary pulmonary hypertension. The Q scan is normal. We look at the CT. If we go firstly to the main pulmonary artery, there is significantly dilated. You see there. In terms of hypertrophy, you can see my cursor up here. The right ventricle outflow tract, you can see that hypertrophy. We look at the cardiac change, left atrium posteriorly, it's squashed, but this is pre-pulmonary disease, severe right atrial dilatation, severe right ventricular dilatation. Very broad effusions are rare in arterial hypertension. This patient was clearly very sick. So right heart catheterization, they've got pre-pulmonary pulmonary hypertension, the pressure is 48 with normal wedge pressure. The PVR is significantly elevated at 10 units, so they've got severe pre-pulmonary pulmonary hypertension with no response to inhaled nitric oxide. This patient has severe idiopathic PAH, and the treatment is to reduce the preload with diuretics, reduce the afterload with those treatments we talked about. Clearly this patient is a movement from class 4, so it's commenced on intravenous prostacyclin therapy, did very well for a good number of years to the transplantation. Different sort of phenotype, 60-year-old female with these risk factors to cardiovascular disease, type 2 diabetes, systemic hypertension, atrial fibrillation. They give you a clue. The ECG, instead of right axis deviation, right heart straight, is atrial fibrillation and left axis deviation. Again gives you a clue as to the likely diagnosis. This is the parasternal long axis, so the left atrium sitting at the back there, which looks dilated, it's very square shaped rather than rectangular. The right ventricle anteriorly there, and the left ventricle leading out into the aorta through there, and you can see my cursor. So this is the parasternal long axis suggesting possibly left heart disease. You'll see on this atrial wall chamber very different to the previous patient. The right ventricle is not dominant, it's not enlarged. The left atrium is enlarged, the right atrium might be slightly enlarged. There's good RV function and a non-dilated RV. So there are markers of LV diastolic dysfunction, so your E to E prime ratio, if it's over, for example, 10 or 9 or 10, certainly over 12, that's suggestive of elevated left atrial pressure. Here the E to E prime is raised. So this patient, you would think, is very likely to have post-critical hypertension. We wouldn't catheterize this patient routinely, but this patient was, the pressure is elevated, the wedge pressure is elevated, the PVR is immediately elevated in previous years. So this is a patient with pulmonary hypertension related to left heart disease, who's not going to benefit from pulmonary vasodilatation. In terms of this is another patient referred with idiopathic PAH period treat. The obvious abnormality here is if you look at the cardiac chambers anteriorly, you see severe right ventricular hypertrophy, which is very rare in idiopathic PAH. It certainly says this disease process is very long-standing and is associated with very significant increased right ventricular afterload. And there was nothing seen in terms of the echo, in terms of defects. The patient is hypoxemic in their feet, but not their hands, which is a big clue, and they've got an erythrocytosis. So, what can you gain from the CT? Well, again, in terms of the things we look at, we're going to one more case after this. The pulmonary artery again, the main pulmonary trunk is significantly dilated with right ventricular hypertrophy, and again, the right side of the chamber is enlarged, not quite as big as on the previous patient. But we've not seen an ASD, either here or the echo. But we're suspicious that this patient may have some form of congenital heart disease. The other thing we should always look at, therefore, is the joint between the aorta and the pulmonary artery. You can see there the descending aorta linking with the main pulmonary artery, this large PDA. So this is a patient with previously undiagnosed PDA who developed isolated syndrome.
Dr. Robin, Dr. Robin, can you hear me? Dr. Robin, yeah, so sorry to interrupt you, but we have some time constraints, so you will be having 2 minutes left. Then we have to stop. Yeah.
I can't actually make you out. Can you say stop? I'll stop there.
Yeah, no, we are really keen to listen. You are given a very good talk. So the 2 minutes are left. So you can continue your talk, and then I just wanted to remind you because there are some time constraints here. Thank you.
So we've got 2 minutes left. I've had a WhatsApp saying 2 minutes left. I'm available for Q&A at the end of the session. Yeah, I can do. No problem. So I'll just finish this one case, and then hopefully I've not gone over time. I couldn't quite hear you. I could see the WhatsApp from your man on the ground there. So 75-year-old, significant smoking history, presented a quite a rapid 2-year history of progressive breathlessness. They're very limited in their exercise capacity. They've said their spirometry. It's notable that they have pretty well preserved spirometry with very low gas transfer. If you remember, we talked about very low gas transfer, suggesting something else is going on rather than standard pre-configured pulmonary hypertension due to PAH. If you just look at the lungs on the CCJ, again you'll see dilated pulmonary artery as before, some hypertrophy, a dilated right heart and a normal left atrium. So again, very much keeping with pre-configured pulmonary hypertension. But if you click on the lung windows, you'll see here very abnormal lungs with severe emphysema. So this is a patient who clearly doesn't have pulmonary arterial hypertension but has pulmonary hypertension related lung disease, the majority of which is mild, but there is this tail at the right of the curve of patients who develop severe pulmonary hypertension, who do less well clearly than any other forms of pulmonary hypertension. We talked about the lack of evidence for treatment and then apart from those patients with idiopathic pulmonary fibrosis. Just the penultimate slide, it's important to remember this is a study looking at patients with acute exacerbation of COPD. During acute exacerbation, patients become hypoxemic and their pressures go up. And you can see after recovery, as the oxygenation improves, pressures come down. So trying not to do an echo during patients with exacerbation, acute exacerbation of their lung disease, as you may think, falsely elevated pressure. So that's the end of the talk. Just to conclude, remember we've got those new hemodynamic definitions. We talked about a diagnostic approach, looking at the history and then the simple tests to try and piece together what we think is the likely diagnosis before you proceed to our heart catheterization where available. We've talked about the different treatments we have and the risk stratification being central to the appropriate therapy of either oral combination therapy or therapy involving IV therapy. We talked about the difficulty with these large number of patients with cardiopulmonary comorbidity and how to approach those. And just to highlight the importance of identifying patients with CTEM. So thank you very much for listening. I hope you can hear me, because I can't quite hear you quite as well. But I hope you can hear me. I think I might have run over a little bit. Apologies for that.
Okay.
I'm happy to answer questions at the end of the session if that's helpful.
Yes, so thank you very much, Professor Robin Condliffe. It was a really very comprehensive review of the disease, and you will stay connected till the end for the question-answer sessions. And now we move to the next speaker, Professor Zillu Humayun. Sir, I'll request you to please take the stage, and he will be talking about preemption and management of pulmonary embolism. Professor Zillu Humayun is a professor of medicine and pulmonology, and he is heading pulmonology unit at Combined Military Hospital, Lahore.